Today we will discuss about the mineral ion homeostasis, particularly calcium, vitamin D, parathyroid hormone, bisphosphonate and different other drugs that will be required for the treatment of osteoporosis. And not only osteoporosis, not only the management of the osteoporosis, we also discuss about how the homeostasis of calcium, vitamin D and other parathyroid hormone etc. are maintained, and what are the different diseases that can occur due to the disbalance of these different types of the elements apart from the osteoporosis. So first, you know that calcium is a very important element in our body. It is needed not only in case of the bones but also needed in case of the, for example, cardiac contraction. It is needed for the smooth muscle contraction, skeletal muscle contraction. It is indeed needed in variety of the micro as well as the macrobiological processes. For example, in the neurotransmitter release, you know, when the neurotransmitters are present in the vesicles, when there is calcium influx, there will be release of the neurotransmitters. So nervous excitement is also dependent of the calcium. Now this most part of this calcium is present in bones. 99% of calcium in our body is present in bone. Only 1% is present in other tissues. And in the bones, mostly it is present in combination with the phosphorus in the form of the hydroxyapatites. So calcium and phosphorus, this mainly forms the bulk of the bones, and if there is microarchitectural deterioration of this bone, that can lead to osteoporosis. Porosis means there will be more pore formation within the bones. For example, this one, like this one. So osteoporosis is basically microarchitectural deterioration. So bones become more fragile. The patients will be more prone to fractures. The fractures may be vertebral fracture, the fractures may be non-vertebral fractures, that is in different other bones. Now when this osteoporosis mainly happens in case of the first is post-menopausal women, because estrogen ultimately provides a support for the bone growth. So in case of the post-menopausal women, there will be decrease of the estrogen levels and there will be some other hormonal milieu changes that ultimately leads to more prone for fragility fractures. So post-menopausal osteoporosis is the most common cause of osteoporosis. The second one is the senile osteoporosis, that is in the old age. With old age, there will be reduction of the calcium, reduction of the vitamin D, which are mainly needed in case of the bone growth. There will be reduction of the testosterone also, that also gives an anabolic effect on the bone growth. All this leads to senile osteoporosis. So these postmenopausal or senile osteoporosis are basically primary osteoporosis. Apart from this, there may be secondary osteoporosis, that is osteoporosis that happens due to some drugs or due to some diseases. We will discuss this later. The most common drug that is also used day in day out and that can lead to osteoporosis is the glucocorticoids. Glucocorticoids induced osteoporosis is very common. So there are most common drugs that can be needed for the treatment of the osteoporosis is the calcium. The first one is the calcium and next is the vitamin D. So calcium, already I have said that 99% of the calcium is present in the bones and rest 1% is present in other tissues. So calcium is a important element that is needed for the bone growth, that is needed for the bone architecture maintenance. Apart from this, this is also needed for the cardiac contraction, needed for smooth muscle and skeletal muscle contraction. This is needed for the different other neurotransmitter release, etc., etc. So when there will be decrease of the calcium level in the blood, that is known as the hypocalcemia, that leads to different types of the deleterious effect. There may sometimes there will be increase of the calcium level. This is known as the hypercalcemia. That is also leads to different types of the problems. Now vitamin D is the vitamin That is basically a hormone. We are telling it vitamin D, but it acts like an hormone that regulates the release of the calcium. Whether the calcium is low or calcium is high, accordingly vitamin D helps it, because vitamin D mainly helps in intestinal absorption of the calcium. And all these vitamin D and calcium, these are regulated by the parathyroid hormone. Parathyroid hormone is a hormone that is released from the parathyroid gland. We have already read in the anatomy what the parathyroid gland is. It is present posterior to the thyroid gland. There are 4 parathyroid glands posterior to the thyroid in our anterior neck. There are 4, 2 in one side, 2 in other side. From this parathyroid gland, parathyroid hormone is released. This parathyroid hormone ultimately tackles this calcium and vitamin D and maintains its balance in the plasma as well as in the bones and different other tissues. So when there is disbalance of this calcium or when there is disbalance of the vitamin D, either the parathyroid hormone will be secreted more or less, and accordingly the balance is maintained. Okay. So let's just continue. So you can see this is the healthy bone. So healthy bone contains the osteoblast cells, osteoclast cells, you know. Osteoblast cells causes the bone growth and osteoclast cells causes the bone resorption. So we discuss in the next class how these osteoblast and osteoclast cells maintain in a cyclic fashion the bone growth, regrowth, bone resorption and again growth. So ultimately if this cycle is disrupted, there will be problems in the bone microarchitecture. So you can see in the osteoporosis there will be more porous bones. That is, the microarchitecture is deteriorated. The mineral content of the bone is decreased because there will be either the calcium is not entering within the bone due to the defective absorption, or the calcium is low, and this calcium is maintained by the vitamin D and the parathyroid hormone. In severe osteoporosis you can see there will be more porous formation. So this is the healthy bone, this is the osteoporosis. What are the problems of the osteoporosis? Already I have told that osteoporosis means there will be more chances of the fragility fractures. So due to the minor trauma, there will be fractures. And this mainly happens in case of the postmenopausal women as well as in case of the elderly persons, in case of the primary osteoporosis. Okay. So coming to the physiological roles of the calcium, already we have discussed. It controls the excitability of the nerves, muscles and regulates the permeability of the cell membrane. The cell membrane permeability is also maintained by the calcium. It also maintains the integrity of the cell membranes. It is an important part of the cell membrane. It maintains the integrity. It is essential for the excitation and coupling of all types of the muscles, be it skeletal muscle, be it smooth muscle, be it cardiac muscle. In all these cases, for the contraction of the muscles, the excitation contraction coupling that needs the calcium. Excitation and secretion of the endocrine and exocrine glands and release of the neurotransmitters from the nerve endings. So you know there are different types of the hormones, different types of the neurotransmitters present in the pre-excited nerve endings. All these are released. The release of the hormones, the release of the neurotransmitters are basically based upon the entry of the calcium within the vesicles. When the entry of the calcium within vesicles happens, there will be excitatory release of the hormones or the neurotransmitters. It is also an intracellular messenger for hormones, autocoids and transmitters. So after the release, the hormones or the neurotransmitters act on the receptors, and after the receptors acting, there will be some post-receptor modifications. The second messenger system is activated so that there will be some effects. So for the effects, we need the second messenger system activation. Here is also calcium plays an important role as a second messenger system. There will be impulse generation and conduction in the heart. So if there is disbalance of the calcium, there will be problems in the heart. There may be arrhythmia. The rhythms will not be maintained. Coagulation of the blood, already we have seen in the hematinics chapter that a coagulation of the blood needed the calcium, and structural formation of the bone and teeth. Most important because 99% of our calcium is present in the bones in the form of the hydroxyapatite. Okay. So functions of the calcium, we can say it forms and keeps strong bones as well as the teeth. So if there is disbalance of the calcium, the bones will be fragile. It helps our nerves carry messages between the brain and the body. That is the neurotransmitter function. Helps our muscles contract. Already I have said. supports normal blood circulation so that the blood will not be coagulated. There will not be thrombus formation, undue coagulation or anticoagulation. The calcium ultimately maintains this and help our bodies release hormones. The hormonal release ultimately needs the calcium. Now coming to the calcium level, the normal calcium level in our body in case of the males is 1.3 gram and in case of the females is 1 gram. So this is the average normal calcium content in our body. Greater than 99% present in the bones and teeth, already I have said. It is regulated mainly by the parathyroid hormone. Apart from this, it is also regulated by the calcitonin and also it is maintained by the vitamin D. And the active form of the vitamin D we will see later is known as the calcitriol. So mainly the parathyroid hormone, vitamin D and less the calcitonin mainly maintains the calcium homeostasis in our body so that the normal content will be maintained. The normal serum calcium level is maintained in a very narrow range, 8.5 to 10.4 milligram per deciliter. So very narrow range, 8.5 to 10.4. So if the calcium content, because it is easier to measure the calcium content from the plasma. So we are mainly measuring the plasma serum calcium concentration when we want to measure. But majority is present in the bones. Majority is present in the bones and tissues. We cannot measure that. So from this we can give an idea what is the amount of the calcium in our body. If the amount in the serum is less than 8.5 milligram per deciliter, it is known as the hypocalcemia. If it is greater than 10.4 milligram per deciliter, it is known as the hypercalcemia. Okay. 40% of this calcium is bound to plasma protein, albumin, 10% is complex to citrate, carbonate and phosphate and 50% is free ionized and important form. You know in every ion the free form is the main form that ultimately leads to different types of the biological functions. So circulating calcium, ionized calcium is the free calcium which is the physiologically relevant compound, mediates calcium, different types of the biological actions already I have discussed in the heart, in the as neurotransmitter, release of the hormones etc and it can be directly measured. Because the calcium that is already bound to albumin or it is already present in the bones, we cannot measure that. So basically we are measuring as a surrogate marker in the plasma calcium. If there is acidosis in our body, that ultimately favors the ionization, that is more calcium will be present in the serum as ionized form. And if there is alkalosis like metabolic alkalosis, that disfavors ionization. So hyperventilation means for example a patient is having chronic obstructive pulmonary disease COPD. Due to the dyspnea, the patient is hyperventilating. So there will be metabolic alkalosis. When there is metabolic alkalosis, there will be less calcium in the plasma, more calcium enters within the tissue. So there will be hypocalcemia. When there is hypocalcemia in the physiology, you have read about the tetany. Hypocalcemic tetany can develop. Laryngospasm can develop in calcium deficiency. When there is severe calcium deficiency or severe hypocalcemia, there will be tetany. Okay. So how this calcium is absorbed? It is absorbed from the entire small intestine including the duodenum, and mainly this absorption is carried out by the vitamin D. It is carried out by the carrier mediated active transport under the influence of the vitamin D. Apart from this, vitamin D also helps in the passive transfer of the calcium within the cell membrane pores. Okay. So vitamin D is needed for the effective absorption of the calcium. So if there is vitamin D deficiency in your body, even if the calcium is, we are taking the calcium from the dietary product, the calcium will not be absorbed as it is needed in our body. Phytates, phosphate, oxalate and tetracycline is a drug. This ultimately reduces the absorption of the calcium. While glucocorticoids and phenytoin, it also reduces calcium absorption. So ultimately these are the different drugs or different substances that is present in foods that decreases the absorption of the calcium. It is mainly filtered through the glomerulus, but again mostly reabsorbed. Again this reabsorption of the calcium in the kidney is dependent upon the vitamin D. Vitamin D increases and calcitonin decreases the reabsorption in proximal tubule. You can see. So that part of the vitamin D, calcium that comes in the kidney, most part of it is reabsorbed back in the body by means of the vitamin D, and calcitonin just acts opposite, that is most part reabsorbed, not reabsorbed and excreted out. Parathyroid hormone increases the distal tubular reabsorption. So in the proximal tubule, calcium reabsorption mainly happens due to the presence of the vitamin D. In the distal tubule, calcium reabsorption mainly happens due to the presence of the parathyroid hormone. And this balance is mainly maintained. What is the amount of the calcium in our body dependent on this? If the calcium in our body is less, there will be more reabsorption because the body will excrete less of the calcium, will reabsorb back more calcium. But if there is sufficient calcium in our body, the reabsorption will be less. 300 milligram of the endogenous calcium is excreted daily in urine and feces, and approximately 75% of this calcium is obtained from the milk and dairy products. So what the calcium main source of the calcium in our body is different types of the dairy products as well as the milk. Adequate intake, that is what is the optimal intake that is needed from our body's well-being. In case of the adolescents is 1300 milligram per day, in case of the adults is 1000 milligram per day, and after age of 50 years, and in case of the postmenopausal approximately 1200 milligram per day. So more or less approximately 1000 to 1200 milligram per day is the adequate intake of the calcium in our body, which is mainly obtained from different dairy products and milk. So these are the calcium preparations, that is calcium when we want to treat if there is some deficiency of the calcium, or if there is some osteoporosis, we are giving some other drugs, and also we have to replenish the calcium, we have to give some calcium tablets. So calcium chloride, calcium carbonate, calcium gluconate, calcium lactate, calcium dibasic phosphate, etc. different formulations. Of these, the most commonly used is the calcium carbonate, calcium gluconate and calcium lactate. And also there is some calcium chloride is lesser used nowadays. Calcium dibasic phosphate is mainly used as part of the antacids, and calcium chloride is also lesser used nowadays. So calcium carbonate contains approximately 40% calcium. It is an insoluble, tasteless and non-irritating salt, reacts with gastric HCl to form chloride and can also be used as an antacid. Calcium gluconate mainly we use, it is also used as an oral form, but mainly we used as an IV formulation, mainly when there is severe calcium deficiency or tetany, or if we want to in some cases, in some other cases, if we need some intravenous calcium preparations, we mainly use the calcium gluconate. So calcium gluconate mainly used as intravenous preparations. Apart from this, it is also used as a oral formulation. Also there is calcium lactate, calcium dibasic phosphate, etc. are present. So calcium absorption and balance, how it is maintained? So calcium intake in our diet, more or less what we are eating, from this we can get 500 to 1000 milligram per day calcium in normal. So dairy products are mainly rich in calcium like milk, cheese, etc. Calcium balance is mainly maintained by absorption from the intestine, and this absorption happens due to the vitamin D. Excretion from the kidneys, again reabsorption happens due to the vitamin D as well as the parathyroid hormone. Excretion happens, some part of this excretion happens in the feces. Movement of the calcium in and out of the bone happens when there is either decrease or increase of the calcium. If there is very much decrease of the calcium in the serum, the calcium will come out from the bones to the serum. So this is known as the resorption of the bone, and this resorption of the bone is mainly done by the osteoclastic cells. Excess goes into the either the feces or the urine, by the kidney or the feces. So by this the calcium balance is maintained. So where this calcium is used, first is tetany. Tetany means when there is severe hypocalcemia, there will be contractions. This is known as the tetanic contractions. Here we need the calcium gluconate IV injections or infusion over 10 minutes, and this is followed by 50 to 100 ml of the calcium gluconate solution over 6 hours. Oxygen inhalation, intravenous fluids are also to be given if the patient is suffering from the tetany. Dietary supplement is given mainly in case of the growing children, in case of the pregnancy, lactating, postmenopausal women, because there is more chances of the osteoporosis, more chances of the decreased calcium absorption. Also in men and women, that reduce the bone loss. Osteoporosis, this is the prevention and treatment of the osteoporosis. Prevention means in postmenopausal women, in senile persons, if we want to prevent the chances of the osteoporosis. Treatment, there are different other drugs of the osteoporosis, but we need the calcium replenishment. In all these cases, we have to replenish the calcium. That is why it is written that along with the different other drugs, we will discuss about this, like hormone replacement therapy, raloxifene and alendronate, to ensure calcium deficiency does not happen. Calcium and vitamin D3 usually used simultaneously as a combination products. It can be used empirically in dermatosis, paresthesia and weakness. This is inexplicable weakness. In those cases, we can use this calcium and vitamin D, and in some other cases, it is also used as antacid. So you can see this is the Trozos sign. You have some read about in the physiology, and again you read about the medicine. This is the telltale sign of the hypocalcemia. When there is hypocalcemia, there will be, you can see, there is hyperextension of some joints and the flexion of the some metacarpophalangeal joints. So this is the Trozos sign. There are different other signs of the tetany that ultimately dictates that the patient have hypocalcemia. That is, calcium level is less than the 8.4. Particularly the tetany is seen when the calcium level is less than 7. Okay. Phosphate is the essential component of the all body tissues. Greater than 80% is present in bone in combination with the calcium in the form of the hydroxyapatite. 15% present in the soft tissues. It exists in the organic and inorganic forms. In extracellular fluid, it is present mainly in the inorganic form, Pi, in the form of the NaH2PO4 and Na2HPO4. In bones, it is complex with the calcium in the form of the hydroxyapatite, and if large amounts are introduced IV or by anemia, catalytic action develops. Particularly, fluoride phosphate deficiency does not usually happen because phosphate is ubiquitous in different types of the foods. Different types of the vegetables we can get phosphate, particularly when there is calcium. Now coming to the vitamin D. Vitamin D is basically a hormone. It is not a vitamin because it is synthesized in the mammals, and under ideal conditions it does not to be taken from the outside food. So usually we can synthesize the vitamin D, but in severe cases when there is vitamin D deficiency happen, we have to treat this by outside vitamin D supplementation. Vitamin D is basically a collective term that is given to anti-rachitic substance synthesized in the body and found in foods that is activated by the ultraviolet radiation. Anti-rachitic means when it was discovered, it has been seen that mainly in case of the sailors, they are suffering from the rickets, and in case of the children. And if they are given some substances that contain the vitamin D, these rickets can be treated. That is, these are known as the anti-rachitic substances. This is also known as the permissive element because that permits the effective absorption and effective action of the calcium. That's why vitamin D is basically a hormone that is also known as the anti-rachitic substance and also known as the permissive element. Vitamin D3 is also known as the cholecalciferol. It is synthesized in the skin under the influence of the ultraviolet rays. Vitamin D2 is known as the argocalciferol. It is present in irradiated food, that is foods, mainly different types of the foods that is obtained from the dairy or from the yeast products that are irradiated with ultraviolet radiation. So this argocalciferol is formed like yeast, fungi, bread, milk, etc. And D1 is basically a unpurified mixture of the anti-rachitic substances. It is not used nowadays. Previously, this combination is used for the treatment of the different types of the rickets or beta calcium deficiency. Calcitriol. Calcitriol is the active form of the vitamin D3. It is more important physiologically, and it is released from the liver in blood and binds to specific vitamin D binding globulin. So how this vitamin D2 or vitamin D3 active form is synthesized? So you can see 7-dehydrocholesterol. So from the cholesterol, 7-dehydrocholesterol is formed. Mainly it is synthesized in our skin. While in case of the yeast, bread, milk, etc., ergosterol is synthesized. Now this 7-dehydrocholesterol or ergosterol, under the presence of the ultraviolet light, that ultraviolet light mainly comes from the sunlight, it is changed to vitamin D3 or vitamin D2. Vitamin D3 is known as the cholecalciferol and vitamin D2 is known as the calciferol. So you can see by means of the ultraviolet light in our skin, 7-dehydrocholesterol is converted to cholecalciferol. Now this cholecalciferol or the calciferol, when this goes through the blood to the liver, within the liver microsomes it enter, within the liver microsomes it happens the 25 hydroxylation. 25 hydroxylation ultimately causes the 25 hydroxy vitamin D3, also known as the calcifediol, or in case of the vitamin D2, 25 hydroxy vitamin D2. Now from this it again comes in the kidney by means of the blood. Within the kidney mitochondria another hydroxylation happens. This is the 1-alpha hydroxylation. So there will be 125 dihydroxy vitamin D3 or 125 dihydroxy vitamin D2 are formed. 125 dihydroxy vitamin D3 is also known as the calcitriol, which is the main active form of the vitamin D in our body that is needed for the different types of the physiological actions, calcitriol. So these are the active forms. So by this way the vitamin D, the active form of the vitamin D is synthesized. So how it is synthesized? Mainly we are concerned with this, and if we are taking some outside food, this pathway ultimately concerned. So in the skin, from the cholesterol, 7-dihydrocholesterol is converted to this cholecalciferol or vitamin D3 by means of the ultraviolet light in the sunlight, and it then comes to the liver. Within the liver, 25 hydroxylation done by the 25 hydroxylase enzymes. So 25 hydroxy vitamin D is formed. This 25 hydroxy vitamin D then comes in the kidney mitochondria, and then another hydroxylation is done by 1-alpha hydroxylase. So 125 dihydroxy vitamin D3 or vitamin D2 is formed. 125 dihydroxy vitamin D3 is known as the calcitriol, which is the main active physiological vitamin D3 that is needed for the different types of the physiological actions. So it is clear how the vitamin D is synthesized and becomes active. So what are the sources of the vitamin D? Sunlight is the most important source, because already you have seen the ultraviolet rays from the sunlight that is needed for the conversion of the 7-dihydrocholesterol to the first form of the ergocholesterol, and then the active form is formed. So mainly in case of the temperate countries or in case of the winter seasons, there will be vitamin D deficiency. But due to our modern lifestyles, because we are less prone to direct exposure to the sunlight, there will be florid vitamin D deficiency. Now it is seen in our tropical countries also. If we test the vitamin D in many persons, you will see that vitamin D is less, and that ultimately leads to less calcium absorption. The bones become osteoporotic and different other physiological functions are also hampered. So usually it is not found naturally in many foods. Most commonly vitamin D is synthesized in our body in the plants. Already we have seen in the plants like yeast etc. ergosterol is present, that can be converted to the 125 dihydroxy vitamin D2. Fluid milk products are usually fortified with vitamin D. What milk? We are mainly the milk that is present in the market. Usually these all are fortified with vitamin D. Okay. So all these milks are usually fortified with vitamin D. Different types of the oily fish or fish liver oil, they are also very rich in vitamin D. Egg yolk, butter, liver. So these are also contains large amount of the vitamin D. Again, already like vitamin B12, as you can remember in the vitamin B12, I have said that the main source of the vitamin B12 is the animal source. So there are some tubers are present, some vegetables. If there is some microorganism infestation, then vitamin B12 can be obtained from the vegetables. Otherwise, in case of the strict vegetarians, for many number of the years, there may be vitamin B12 deficiency. Similarly, vitamin D also may be deficient in case of the strict vegetarian for a long period of time. But in most of the cases, since the milk or the milk products are fortified with the vitamin D, in our modern scenario, the vitamin D deficiency is rare in case of the vegetarians. Okay. So you can see vitamin D is present in the cheese, eggs, tuna fish, salmon fish, milk, sunlight, fortified cereals. These are the milk. So milk and milk products are the main source of the vitamin D. Remember. Okay. So now what is the actions of the vitamin D? What is the actions of the calcitriol, the active form of the vitamin D? From the first, I have said the vitamin D is mainly instrumental in absorption of this calcium. Without the vitamin D, the calcium absorption will be hampered. So it causes the enhancement of the absorption of the calcium and phosphate from the intestine. So how this enhancement, how this mediator happens? By increasing the synthesis of the calcium binding protein. This is basically a calcium channel or cal binding. See, this calcium binding protein binds the calcium and helps in absorption within the intestinal cells. It is also analogous to the steroid hormones. It binds to cytoplasmic vitamin D receptor. So this vitamin D receptor present on the cytoplasm, then translocated inside the nucleus. So increased synthesis of the mRNA happens within the nucleus and regulation of the different protein synthesis happens. So if there is vitamin D deficiency, different protein synthesis will be deleterious. So when we are giving the vitamin D, activation of the vitamin D receptor ultimately promotes the endocytotic capture of the calcium. So the calcium will be captured endocytotic and transport across the duodenal mucosa. That's why even if we are in case of the severe calcium deficiency or in case of the osteoporosis, we are giving the vitamin D, there will be quick effect as well as the long term effect. Why the quick effect of the vitamin D on calcium absorption happens? Because there will be endocytotic capture of the calcium due to the presence of the vitamin D, and this calcium ultimately transported across the duodenal mucosa. And in the long term, there will be more synthesis of the calcium binding protein, and this calcium binding protein ultimately helps into more and more calcium capture, and this calcium are entering with the intestinal cells. Okay. Next is enhances recruitment and differentiation of the osteoclast precursors for remodeling. From resorption of the calcium and phosphate from the bone happens. What does it mean? So when there is calcium deficiency or less calcium in our body, the balance will be shifted from bones to the serum. That is, there will be resorption of the bones. Resorption means the calcium that is present in the bones, some part of it resorbed and ultimately comes in the serum. And this happens due to the vitamin D. Because vitamin D ultimately recruits, ultimately differentiates, that is activates the osteoclast cells. And this osteoclast cells causes resorption of the bones. The bones will be resorbed. So the calcium that is present within the bones, that will be released, that will comes in the serum. So ultimately mature osteoclast lacks the vitamin D receptor. They induces the receptor for activation of nuclear factor kappa beta ligand. This is known as the rank ligand in osteoblast and activates osteoclast indirectly. So osteoclast does not have the vitamin D receptor on its own. Basically, when there will be calcium deficiency, the osteoblast cells, they are basically activated. Osteoblast cells activates the osteoclast cells. So osteoblast activated osteoclast cells, and this activation happens by means of this rank ligand. So ultimately that leads to laying down and mineralization of the osteoids. It mainly appears to help bone mineralization indirectly by maintaining normal plasma calcium and phosphate concentration. So when the resorption happens, the calcium will come to the serum. So ultimately normal calcium homeostasis will be maintained. Then again the new bone formation happens. So there will be a normal cycle will be maintained. So it does not like that the bone will be destroyed like resorption. So resorption of the bone as well as the bone formation is a cyclic process. So if there is no resorption, there will be uneven maturation of the bones. That leads to problems. So there will be resorption of the bones and again the regrowth of the bones. And when there will be calcium is less, the vitamin D ultimately activates the osteoblast cells, that activates the osteoclast cells. Resorption of the bones happens, calcium comes in the plasma, the calcium homeostasis will be maintained, rest of the calcium again it comes to the bones and again the regrowth of the bones will happen. It also enhances the tubular reabsorption of the calcium. Already I have said, mainly in the proximal tubules, the main part of the calcium that comes in the kidney, it has been reabsorbed back in our body. Apart from this, the lymphokine production, proliferation and differentiation of the epidermal and certain malignant cells, neuronal and skeletal muscle functions, all these are dependent on the vitamin D. So these are the main functions of the vitamin D. enhancement of the absorption of the calcium and phosphate, and this happens due to these mechanisms. So either they happens due to the increased synthesis of the calcium binding protein, okay, they causes endocytotic capture of the calcium in the intestinal cells. That's why there will be more calcium absorption within the intestinal cells. Next is, if the calcium level is less in our body, there will be more resorption of the bone, so that the calcium will come from the bones to the plasma, and then if the calcium homeostasis is maintained, then again the normal growth of the bone will continue. The third is, that causes the proximal tubular reabsorption of the calcium. That is, the calcium that comes in the kidney reabsorbed back in the body. And this reabsorption, what amount of the calcium will be reabsorbed depends upon the amount of the calcium in our body. So if it is less, there will be more reabsorption. So apart from this, there are some miscellaneous functions of the vitamin D. So now coming to the pharmacokinetics, it is absorbed from the intestine in presence of the bile salts, mainly in the lymphatics, the vitamin D absorption. DT is better absorbed than the D2. That's why the DT is always it is preferable to replenish. It binds to alpha globulin and stored in fatty tissues for many months. The half-life of different forms varies. That is D3, the longest half-life. The different others like 25 hydroxy D3 or only D3, they have different types of the half-life. The metabolites of the vitamin D are excreted mainly in the bile. So unitage, how it is usually measured, 1 microgram of the cholecalciferol is equivalent to 40 international unit of the vitamin D. The daily requirement usually varies depending on exposure to sunlight. What I am telling, in case of the temperate countries, in case of the countries with snow, or in case of the severe winter in the northern countries, like in the Nordic countries, there will be severe vitamin D deficiency. It is estimated that if no vitamin D is synthesized in the body, a dietary allowance of the 400 international unit per day will prevent deficiency symptoms. That is, the adequate intake is 400 international unit of the vitamin D per day. Okay. Calciferol, cholecalciferol, calcitriol, all these can be replenished. The different formulations are there. Calcitriol analogs, they binds poorly with vitamin D binding globulin, clearance is faster and less risks of the hypercalcemia. That's why calcitriol analog, that is the active form of the vitamin D3 analog, are mainly used for the treatment or management. Alpha calcidol is another product that can be also be used as a drug, rapidly hydrolyzed to calcitriol in liver. It is equally active to calcitriol on long-term use. Similarly, calcipotriol, doxocalciferol, pericalcitrol, etc. is present. It is also needed in different other diseases, different other epidermal diseases also, these are needed. So you can see that our body needs all forms of the vitamin D. So already we have discussed vitamin D from the sunlight in the epidermal cells. So vitamin D3 is made in the skin, is used by the skin cells, and ultimately if that vitamin D is present in our body sufficiently, DNA damage will be less, cell death will be less, DNA repair will be more. Vitamin D3 is the cholecalciferol that is taken directly into cells for local conversion and use. Already we have discussed. Most potent form for endothelial stability also, endothelial stability, our blood vessel stability, their integrity is also dependent on the vitamin D3. It is an anti-inflammatory substance. Form is needed by breastfeeding mothers to transfer the baby to breast milk. So breast milk contains high amount of the vitamin D3. So baby gets vitamin D3 from the breast milk. Must receive daily or semi-daily due to very short half-life to roughly 24 hours. Half-life is less. 25 hydroxy vitamin D is also known as the calcifediol. Also already we have seen, it is the form measured in blood as indicator of the vitamin D status. Mainly we are indicating this 25 hydroxy vitamin D. When you need to measure the vitamin D in our body, you have to write that a 25 hydroxy vitamin D in our body. From this we can get an approximation of how the vitamin D is present in our body or not. It is taken directly into the cells and converted to the 2-hydroxylation, 1-hydroxylation, 25 hydroxylation. It is mainly used as a signaling molecule in most cells and tissues, including immune, brain, blood vessel, heart, lungs, and many more. And 125 dihydroxy vitamin D calcitriol is the main thing. Already I have discussed everything about this. Like the main thing is the calcium absorption in our body that is needed. Now, where the vitamin D is used? prophylactic as well as the treatment. Prophylactic 400 international unit per day and treatment in a higher dose 3000 to 4000 international unit per day, mainly in case of the rickets and osteomalacia. So alternatively, we can use oral or intramuscular injections of the 3 to 6 lakh international unit every 2 to 6 months interval. So there may be different types of the rickets. First one is the metabolic rickets also can happen. What is this? This is a group of conditions in which tissues do not respond to normal doses of the vitamin D. So metabolic rickets, the vitamin D, the body are not having the vitamin D even if there is presence of the vitamin D. One thing is the vitamin D resistant rickets. This is basically a X-linked hereditary disease in which the vitamin D metabolism is normal, but calcium and phosphate metabolism is deranged. So vitamin D metabolism is normal. Vitamin D also helps in the calcium absorption, but the metabolism of the calcium and phosphate will be deranged. So here we need the treatment of the phosphate with high doses of the calcitriol is needed in vitamin D resistant rickets. That means here the rickets, calcium or vitamin D deficiency is there. We are giving the vitamin D, but they are not responding. That's why vitamin D resistant rickets. It is a hereditary disease. Vitamin D dependent rickets. It is another genetic disorder due to deficiency of the renal hydroxylating mechanism. That is already we have seen the 1-alpha hydroxylation happens in the renal kidney mitochondria. So if there is some problems in the kidney, if this hydroxylation mechanism will not happening in the kidney, so ultimately the active form of the vitamin D will not be formed. So this is a vitamin D dependent rickets, because if we are giving the active form of the vitamin D, that is 125 diacid vitamin D, already the hydroxylation already it has been done, so ultimately it can be treated. So administration of the calcitriol is effective in normal doses. Another is the renal rickets. Renal rickets is conversion of the 25 hydroxy vitamin D3 into calcitriol does not occur due to chronic renal disease. This happens if the patient is on dialysis. For example, chronic kidney disease due to uncontrolled diabetes mellitus for a long period of time, that leads to diabetic nephropathy, or due to the uncontrolled hypertension for a long period of time, hypertensive nephropathy, or due to some renal parenchymal disease, the kidney will be deranged or the patient have to do dialysis for its survival. In those cases, there will be severe deficiency of the vitamin D, and that is known as the renal rickets. So we need the calcitriol or alpha calcidol or dihydrotachisterol for the treatment. Okay. Senile or postmenopausal osteoporosis, we need the combination of the calcium and vitamin D, because vitamin D is needed for the calcium absorption. Hypoparathyroidism, already in the first I have said that from the parathyroid gland, parathyroid hormone is secreted. If there is hypoparathyroidism, that is parathyroid hormone is secreted less, again that leads to hypocalcemia, the vitamin D will be less. So dihydrotachisterol, calcidol or alpha calcidol can be needed in case of the hypoparathyroidism. Fanconi syndrome is another syndrome that is also associated with the problems in the kidney. Vitamin D can raise the lower phosphate level that occurs in this condition. And psoriasis. Psoriasis is a skin condition, again an autoimmune disease where there is disruption of our normal skin, epidermis. So calcitriol, which is a vitamin D analog, that is used topically for the treatment of the psoriasis. So from this you can see the vitamin D is needed not only in case of the osteoporosis, but it also be needed in different types of the metabolic diseases, particularly different types of the metabolic rickets. That may be vitamin D resistant rickets, vitamin D dependent rickets, or that may be renal rickets, that may be different types of the epidermal autoimmune disease like psoriasis, that may be hypoparathyroidism and different types of the osteoporosis. So vitamin D deficiency, ultimately in case of the children it leads to rickets, and in case of the adults, if there is long standing deficiency of the vitamin D, that can lead to osteomalacia. So rickets is mainly characterized by different types of the osseous changes. Like in the head there may be craniotapes, frontal bossing, box-like skull, delayed closure of the anterior fontanelle. In the teeth there may be delayed eruption, abnormal odor. In the chest there may be rachitic rosary like pigeon chest or funnel-shaped chest. In the spinal column there may be bending of the spinal column will be different. There may be scoliosis or kyphosis or the lordosis. That is, there are the normal curvature of our spinal column. that normal curvature will be lost. There may be bow legs. The legs will be bowed. Rachitic dwarfism can happen. In the muscular system, there may be pot belly, late in standing and walking. Motor development is delayed because they are children. Other nervous and mental symptoms also can happen. So you can see, this is the pot belly, this is the bow legs, this is the rachitic rosarian pigeon chest, this is the pot belly, you can see. This is the typical child with a Rickets. Okay, so you can see this is the typical bow legs. Legs are bowed. Okay, legs are bowed. Okay. So treatment, we need mainly the vitamin D therapy. High doses of the vitamin D is to be given. 2000 to 4000 international unit per day for 2 to 4 weeks. Then change to preventive dose. A single large dose is often needed. And in case of the, you can see for the prevention, we need to prevent this rickets. So in pregnant and lactating women have to take a normal adequate intake of the vitamin D. This has to be done by means of the supplementation, by means of the adequate food intake. Advocate sunbathing. Advocate breastfeeding. Already we have seen breast milk contains large amount of the vitamin D. Vitamin D supplementation in prematures, twins and weak babies. For term babies and infants, in those cases, you can see these are the different types of the amount of the vitamin D that is needed for the treatment. Now coming to the osteomalacia. So in case of the adults, when vitamin happens, that leads to osteomalacia. So there will be incomplete mineralization of the normal osteoid tissue following closure of the growth plates. Rickets happen before closure of the growth plates because they are children. Growth plate closure will happen in the adolescence. So before closure of the growth plate happens, that's why there will be changes in the bone structure. There will be bow legs, scoliosis, kyphosis, rachitic rosary, etc. But in case of the adults, the growth plate already are closed. So ultimately there will be incomplete mineralization within the bones. So the bones will be soft. There will be bone pain, easy fracture, bone fractures, compressed vertebra, muscle weakness can happen. In the X-ray, there will be typical feature. You can see there will be, this is the radiograph, generalized osteopenia and a linear lucency representing a loser zone. So this is a linear lucency. Lucency means there will be increased uptake, increased lucence. So that can happen due to the incomplete mineralization of the bones. This is the medial cortex of the femur. This is a telltale sign of the osteomalacia in case of the adult. Again, toxicity of the vitamin D can happen, hypervitaminosis D. So in case of the vitamin D, usually if there are vitamin D deficiency, the patient suffering from osteomalacia or the patient complaining of the pains in the bones, we are using a large amount of the vitamin D weekly. Okay, first, and then if it is ultimately it is supplemented, then it is given monthly and then it is stopped. But if the patient is already have adequate vitamin D or we are giving some large amount of the vitamin D, hypervitaminosis D can also happen. So that hypervitaminosis D ultimately causes hypercalcemia. That is, the calcium level is also increased because there will be more intestinal uptake of the calcium. So there may be nausea, vomiting, excessive thirst, polyuria, anorexia, severe itching, joint muscle pain, disorientation, coma, calcification of the soft tissues like lung, heart, blood vessels, excess blood calcium leads to stone formation. Hypercalcemia or this hyperparathyroidism or hypervitaminosis D is mainly present with some stones in the kidney. Stone formation happens due to the large amount of the calcium. So again, in case of the hypercalcemia, there will be changes in the ECG. So there will be, after the QRS complex, there will be sudden upstroke. This is known as the Osborne wave. So again, it has been Osborne wave is seen in case of the hypercalcemia. Hypercalcemia can happen due to the hypervitaminosis D. Hypercalcemia can happen due to the hyperparathyroidism also. We will discuss. Okay. So recommended daily allowance, already we have discussed, more or less calcium we need approximately 1000 to 1200 or 1300. Vitamin D approximately we need 400 to 600 in different age groups. In the children that will be lesser, in the adult there will be more, that will be still more in case of the elderly and postmenopausal women. Next, coming to the parathyroid hormone. In the first I have said that the parathyroid hormone mainly controls all this homeostasis of the calcium and vitamin D. And this parathyroid hormone is secreted from the parathyroid glands. There are 4 parathyroid glands that are present posterior to the thyroid gland in our anterior neck. This is secreted by the principal cells of the parathyroid gland. It is secreted by a 115 amino acid, large amino acid molecule known as the pre-pro-parathyroid hormone. This pre-pro-parathyroid hormone then cleaved within the endoplasmic reticulum into the pro-parathyroid hormone. Then it comes within the Golgi bodies and then it is from 84 amino acid parathyroid hormone. Okay. So hypocalcemia is a principal factor that regulates the parathyroid synthesis and release. So when there is hypocalcemia, the calcium level in the serum is less, the parathyroid gland secretes more parathyroid hormone and it is mediated through activation of adenylate cyclase and subsequent increase in the CAMP level. So what are the actions of the parathyroid gland? The primary function is to maintain a constant concentration of the calcium and the inorganic phosphate in the extracellular fluid. That is constant concentration, homeostasis of the calcium and phosphate. The principal processes regulated are the renal calcium and phosphate absorption and mobilization of the bone calcium. So these actions of the parathyroid hormone are mainly mediated by the 2 receptors, parathyroid hormone 1 and parathyroid hormone 2 receptors. These are mainly G protein coupled receptor. Okay, so these are example of the G protein coupled receptor. So plasma calcium is the major factor, already we have seen. If the concentration of the calcium diminishes, parathyroid hormone secretion increases and vice versa. So what are the actions? Parathyroid hormone mainly acts on the bone, on the kidney and in the intestine, 3 areas. In the bones, parathyroid hormone promptly increases resorption of the calcium from bone. So mainly it helps in the resorption of the calcium. So calcium is resorbed from the bones to the serum. This is the most prominent action of the parathyroid hormone exerted by increasing the number of the bone remodeling units. Bone remodeling units are mainly formed by the osteoclast cells. So these osteoclasts are activated when high concentrations are present continuously. But it has been seen when this parathyroid hormone is given intermittently or intermittent burst of the parathyroid hormone is given from outside, there will be more bone formation rather than bone resorption. So on the one hand, if we are giving continuous high dose parathyroid hormone, that causes more bone resorption than the bone formation. But if we are giving intermittent dose of the parathyroid hormone or intermittent release of the parathyroid hormone, that mainly happens physiologically, that causes more bone formation, less bone resorption. So bone resorption usually followed by bone deposition or bone formation. So this is also promoted by the parathyroid hormone. So already I have said it's a cyclical process. So ultimately increased bone formation occurs when this parathyroid hormone is given intermittently and in low doses. So remember, parathyroid hormone only when it mainly causes good bone formation when it is given intermittently and in low doses. But if it is given in high dose or if it is given in a continuous process, that ultimately leads more bone resorption rather than bone formation. In the kidney, parathyroid hormone increases the calcium resorption in the distal tubule and provides moment to moment regulation of the calcium excretion. So proximal tubular reabsorption mainly happens due to the vitamin D and distal tubular reabsorption of the calcium mainly happens due to the parathyroid hormone. It also promotes the phosphate excretion, that is, this is in contrast to vitamin D. Vitamin D promotes both calcium and phosphate reabsorption in the kidney. But parathyroid hormone causes reabsorption of the calcium in the kidney but more excretion of the phosphate in the kidney. That is opposite. Okay. In the intestine, parathyroid hormone has no direct effect on the calcium absorption, but it increases indirectly by enhancing the formation of the calcitriol in the kidney by activating the 1-alpha hydroxylase. So mainly they activates the 1-alpha hydroxylase in the kidney. So mainly they activates the vitamin D. There will be more availability of the active form of the vitamin D. So calcitriol then promotes intestinal absorption of the calcium. So indirectly it helps in more calcium absorption in the intestine. Parathyroid hormone decreases the calcium levels in the milk, saliva and ocular lens. This may be responsible for the development of the cataract in hypoparathyroidism. So when the parathyroid level is less, there will be cataract formation due to the less calcium in the lens for a long period of time. It is rapidly metabolized in the liver and kidney. Half-life is very less, 2 to 5 minutes. Hence, it cannot be used therapeutically. That's why the newer formulations, some new formulations are needed for the parathyroid hormone supplementation. So, this is by which the balance of the calcium, vitamin D and the parathyroid hormone is maintained. So, you can see the parathyroid hormone ultimately leads to more calcium release, high blood calcium. Calcium absorption happens from the intestine. There will be active vitamin D that ultimately leads to more reabsorption of the calcium of the kidney, and ultimately in the bones there will be more resorption of the bones if there is continuous high dose parathyroid hormone. If there is intermittent parathyroid hormone, there will be more bone formation. So recombinant parathyroid hormone or teriparatide is the drug that is needed for the parathyroid hormone supplementation. So that stimulates new bone formation on the trabecular and cortical bone surfaces by preferential stimulation of the osteoblastic activity over osteoclastic activity. Okay. So teriparatide is the drug, main drug. Daily subcutaneous injections for the treatment of the severe osteoporosis. In severe osteoporosis, we have to give daily subcutaneous injections of the teriparatide. Diagnostic use, it can be used to differentiate pseudo hypoparathyroidism and true hypoparathyroidism. Teriparatide, if it is given IV, plasma calcium levels fails to rise, then it is pseudo hypoparathyroidism. This is a different disease, details is not required. Side effect is occasional headache, dizziness and leg cramps can happen. So teriparatide, before giving teriparatide, we always have to rule out the secondary hyperparathyroidism and we have to treat the vitamin D deficiency. May not be potently active if parathyroid hormone is very high, greater than 100 picogram per ml. It is not to be used in chronic kidney disease, not to use in patients with past malignancies because there will be severe rise of the calcium, hypercalcemia can happen. We have to follow up with calcium after 1 month. That is to see whether the calcium is very high or very less. Bone turnover marker like PRNP also we have to measure, that is whether the bone growth is adequate or not in case of the osteoporosis. Rarely hyperuricemia can also happen. So there are features of the patients who may benefit from long-term teriparatide use. Whom to give teriparatide? Kake debo? So very high fracture risks, unable to come off glucocorticoid therapy. So already in the first I have told that glucocorticoid is the drug that causes severe osteoporosis. So here we can give high fracture risks with P1NP, that is the bone turnover marker that remains high after 2 years on teriparatide. High fracture risks with multiple vertebral compression fractures at baseline but none while on teriparatide. Adynamic renal bone disease like renal rickets, different types of renal rickets. Severe chronic obstructive pulmonary disease because there will be severe metabolic alkalosis, there will be severe derangement in the calcium and vitamin D resorption and vertebral compression fractures can happen. So you can see these are the types of the parathyroid hormone therapy. Like this is the teriparatide already we have discussed. This is the biologically active N-terminal fragment of the parathyroid that maintains the serum calcium. Usually the once daily or twice daily dosing is needed. Apart from this, there are some newer parathyroid hormone analogs like NEET-PG. NEET-PG is the parathyroid hormone 1 to 84 analogs. That is the intact native hormone that replaces full physiological parathyroid hormone that allows reduction in calcium and active vitamin D requirements. Once daily dosing is effective that improves biochemical control and long-term outcomes. And there is another some long-acting parathyroid hormone analogs like peg-paratide, teriparatide, that is PGylated derivative of the these parathyroid hormones, that is the modified parathyroid hormone that causes the sustained release once daily dosing. So you can see this is the emerging therapies of this, like this eniboparatide, enacardiate, sustained release parathyroid hormone, some infusion pump therapy. Ultimately, they leads to different types of the changes in the parathyroid component like PGylated parathyroid component that ultimately leads to long-acting parathyroid or oral some parathyroid hormone receptors. because there are many persons are now suffering from the osteoporosis, many persons are suffering from the hypoparathyroidism, and since the native this parathyroid hormone, the half life is very less, so this teriparatide have to be given many doses. So the long acting drugs, newer analogs needed to be taken, and these are also very much costly. So this is the different types of the newer parathyroid hormones, like eniboparatide, just remember the name, eniboparatide, N-calritate, sustained release parathyroid hormone, some infusion pump therapy, pegylated derivative of the parathyroid hormone, some oral parathyroid receptor agonist, etc. So cinacalcet is the calcium sensor mimetics. Details is not required, just remember this is a drug that is mainly needed in case of the hyperparathyroidism, secondary hyperparathyroidism, and also the adverse effect in the hypocalcemia, because they activates the calcium sensing receptor in our parathyroid gland. So lastly, the hyper and hypoparathyroidism already we have discussed. The hyperparathyroidism, hyper mainly happens due to the presence of the adenoma. Most commonly there will be some parathyroid adenoma, or in some cases carcinoma, that leads to more parathyroid hormone release. This hyperparathyroidism is associated with hypercalcemia. Hypoparathyroidism is mainly associated mainly in case of the surgical rejection. That may be inadvertent surgical rejection due to thyroid surgery or due to hypoparathyroid surgery, that leads to very less parathyroid hormone. So here also hypocalcemia can happen. So in case of the hypoparathyroidism, we have to treat the hypocalcemia, we have to treat the vitamin D, etc. But in case of the hyperparathyroidism, we have to treat the increased parathyroid hormone level, like we have to give the cinacalcet level, we have to give the low calcium high phosphate diet, etc. So this is all about the calcium, vitamin D and parathyroid hormones. From the next class we will discuss about the other therapies that is needed for the osteoporosis treatment. Thank you.